My presentation is on cognitive behavioral techniques for the treatment of schizophrenia. On slide 2, schizophrenia is a disorder characterized by positive symptoms such as hallucinations, delusions, and disorganized speech, thoughts, and behaviors. It is also characterized by negative symptoms such as flat affect, low energy, and social isolation. And the third characteristic of schizophrenia is cognitive deficits, which include poor concentration, memory deficits, and disorganized thinking. Schizophrenia typically affects 0.5 to 1.5% of adults across the globe. On slide 3, antipsychotic medications are the primary method of treatment because they reduce positive symptoms, but they do not relieve all symptoms for all patients, and they often have undesirable side effects. The goals of psychotherapy for schizophrenia on slide 4 are to reduce symptomatology, improve client functioning, and increase medication efficacy through compliance. This presentation seeks to examine some of the literature on cognitive behavioral techniques used in the treatment of schizophrenia. A study conducted by McFarlane et al. In 1995 was conducted over a period of 2 years and compared the efficacy of multiple family group treatment to single family treatment. Multiple family group treatment consisted of sessions of 6 families with 2 clinicians, and single family treatment was sessions of 1 family with 1 clinician. Both conditions have psychoeducational components and focus on developing coping and problem-solving skills through manualized treatment. And in both of the conditions, the patients may decline to attend the sessions. The researchers hypothesized that multiple family group treatment would produce greater reductions in relapse rates, symptomatology, and functional deficits than single family therapy, and that both treatments would result in a decrease in hospitalizations as compared to treatment as usual. Moving on to slide 6, the results show that multiple family group treatment resulted in significantly fewer relapses, 38 versus 60, than the single family treatment. Multiple family group treatment was most advantageous for clients with more severe levels of symptomatology at baseline. The researchers speculated that multiple family group is more effective due to the expansion of the family social network and the generation of increased options for problem solving by the group. Moving on to slide 7, some criticisms of the study are that the authors did not specify what specific coping and problem-solving techniques were included in the treatment manual. According to their protocol, participants could not receive any other form of psychotherapy, yet attendance at a partial hospital facility, vocational and recreational therapies were allowed. They also did not specify how many patients in each group took advantage of these services and whether or not it affected the study results. They used medication compliance as one of their outcome measures, yet people that exhibited poor compliance at the outset were prescribed injections, which creates a confound. They stated that the patient is encouraged but does not need to be present during the family sessions. They did not attempt to explain exactly how the treatment benefits the patient if they are not present at the therapy, and they did not report any data on the number of patients that did attend. While the authors concluded that multiple family group treatment was an effective method for preventing relapse of symptoms and increasing functioning, this approach would only be beneficial to patients with a high level of family involvement in their care. On slide 8, a study conducted in 1999, the researchers randomly assigned a group of 41 patients with treatment-resistant schizophrenia who had recently began clozapine therapy to receive either cognitive behavioral therapy in conjunction with social skills training or individual psychotherapy. They wanted to demonstrate the impact of combining cognitive behavioral therapy with clozapine. The cognitive behavioral therapy condition placed an emphasis on problem solving and included modeling, in vivo exercises, self-care and medication management training, reality testing, and Socratic questioning. The individual therapy condition included psychoeducation, active listening, and crisis management. On slide 9, the results show that Dependent measures included scores on the Brief Psychiatric Rating Scale, the Scale for Assessment of Positive Symptoms, and the Scale for the Assessment of Negative Symptoms. The results showed that the Cognitive Behavioral Therapy group had improved Brief Psychiatric Rating Scale scores and Assessment of Positive Symptom scores. There were no significant improvement on negative symptom scores between the two treatment groups. On slide 10, in summary, while the researchers set out to demonstrate the effectiveness of combining clozapine therapy with cognitive behavioral therapy, they failed to compare the combination to cognitive behavioral therapy alone or clozapine alone. Although clozapine is praised for reducing the occurrence of extrapyramidal side effects, it is important to note that 2 participants were forced to discontinue their clozapine and drop out of the study due to the development of leukopenia, which is a decrease in the white blood cell count, and the patients also experienced seizures. Despite some shortcomings, the authors present a convincing case that cognitive behavioral therapy combined with clozapine is an impressively effective intervention for treatment-refractory schizophrenia. On slide 11, a 2000 study, the researchers pointed out that while previous studies on the efficacy of cognitive behavioral therapy in the treatment of schizophrenia appeared to be promising, they were also wrought with methodological flaws. One of their criticisms of previous work was that some studies involved intensive cognitive behavioral therapy that would be impractical for use in vivo. In their current study, one group received cognitive behavioral therapy as outlined by a treatment manual written by the authors for the purposes of practicality and experimental control. The second group was exposed to a condition termed befriending, in which the therapy sessions were not goal-directed and discussion was focused on superficial topics such as hobbies or sports. The 2 treatments were delivered by nurses under the supervision of the researchers. Blind raters also assessed a sample of audio tape sessions for the purposes of quality control. Results show that both interventions were effective in reducing positive and negative symptomatology, but the cognitive behavioral therapy group displayed sustained and continued improvement at a 9-month follow-up. Participants in the study also showed improvement in their negative symptom scores post-intervention. Mean scores in the cognitive behavioral therapy condition dropped 17.7 points at follow-up, and scores in the befriending group dropped 5.9 points. Moving on to slide 13, a 2000 study, the researchers developed the Rehabilitative Coping Skills Module, which is a 7-step process of symptom identification, cognitive appraisal of stress, cognitive appraisal of change and resources, selection of coping strategies, use of selected coping strategies, and evaluation of results. The researchers incorporated problem solving with cognitive behavioral therapy in the form of 24 one-hour group sessions. The experimental group received treatment as usual in conjunction with the coping skills module, and the control group simply received treatment as usual. On slide 14, the results were not very striking, but the module group displayed a statistically significant decrease in symptomatology, specifically delusions, an increase in self-esteem, and an improvement in personal hygiene. However, the authors seem to take some liberties with the interpretation of their results within the discussion section of the article. They stated that there is a conceptual association between hygiene and negative symptoms, and their findings suggest that the coping skills module contributed to a decrease in negative symptoms, although their specific measure of negative symptoms did not reflect that. They reported that staff reports of patient improvement are more reflective of the module's efficacy than the data itself. And they did not address the fact that since the majority of the subjects were French-Canadian, some of the assessment tools had to be translated into French, and there were no reliability or validity data presented for the translation. Moving on to slide 15, Terrier et al. In 2000 conducted a 2-year follow-up of a previous study they had conducted in 1990.